Imagine a patient, let's call her Mrs. Davies, walks into your clinic, she's say 72, and her biggest complaint is this relentless, aching lower back pain. And it radiates down both her legs, especially when she's been standing in the queue at the supermarket or, walking the dog.
Mm-hmm.
She tells you the only real relief she gets is when she leans forward over her shopping trolley, or perhaps when she sits down.
A familiar story.
Exactly. This scenario, or something very like it, it's quite common in daily practice, isn't it? And it presents a real diagnostic challenge given how many conditions can present with these, well, seemingly straightforward symptoms.
Absolutely. It's often more complex than it first appears.
So today, we're embarking on a deep dive into one of the most significant and often perplexing culprits behind these very symptoms in adult populations, lumbar spinal stenosis, or LSS.
Right.
Our mission with this deep dive is really to distill critical insights into this condition. We want to move beyond just the textbook definitions, uncover those perhaps surprising facts and practical nuggets of knowledge that genuinely enhance your clinical decision-making.
Good aim.
We'll explore everything from its subtle underlying mechanisms right through to the cutting edge of diagnosis and treatment strategies. And this is specifically tailored for you, our mid to senior medical professional audience. And joining us as our expert guide on this intricate journey is Prof. Mo Imam. Welcome.
Thank you. It's a pleasure to be here. Lumbar spinal stenosis is indeed a prevalent and, well, often profoundly complex condition in clinical practice. It affects a significant and, frankly, ever-growing portion of our aging population. It's a diagnosis we certainly encounter with increasing regularity, and its nuances definitely warrant a comprehensive and perhaps even a fresh exploration.
So let's unpack this straight away, right from its very core. What exactly is lumbar spinal stenosis, and why does it hold such a significant position, in terms of clinical impact within adult populations?
Okay. At its most fundamental, lumbar spinal stenosis is defined by a pathological narrowing of production in space within the spinal canal itself, or perhaps within the neural foramina.
Those little bony openings.
Precisely. The small bony openings through which the nerve roots exit the spine, specifically within the lumbar region. Now, this narrowing, and this is the critical point, inevitably leads to compression of the neural elements housed within.
So the nerves themselves.
Yes, we're talking specifically about the spinal cord. If the stenosis happens to be high enough in the lumbar spine, although that's less common. More typically, it's the individual nerve roots as they descend through the canal and prepare to exit.
Right.
And while it can affect younger patients, perhaps due to congenital or developmental factors, LSS is overwhelmingly a degenerative condition. It typically affects individuals age 60 and older.
So it creeps up on people.
Often, yes. Presenting with symptoms that may have been silently progressing for many years, even decades, before they become overtly problematic enough for the patient to actually seek medical attention.
You've painted a picture of this gradual, almost silent progression. So if we think about the anatomy involved, what are the key components of the lumbar spine that become implicated in this narrowing process, and why are they so vulnerable?
Certainly. The lumbar spine, our lower back, it's an incredibly robust yet surprisingly flexible structure. It comprises 5 distinct vertebrae, typically labeled L1 through L5. These vertebrae are positioned crucially between the rib cage and the pelvis, forming the very foundation of our axial skeleton. Now, nestled between each of these bony vertebral bodies are the intervertebral discs.
Shock absorbers.
Exactly. But they're far more than just passive spacers. They are dynamic fibrocartilaginous structures, essential shock absorbers, allowing for remarkable flexibility while cushioning the spine against compressive forces. Running centrally through this stack of vertebrae is the spinal canal itself.
The main channel.
Yes, a vital protective conduit for the spinal cord, which typically ends around the L1 or L2 level, and then the intricate network of nerve roots that branch off it, forming what we call the cauda equina.
The horse's tail.
Indeed. Supporting this entire complex structure is a sophisticated network of ligaments and muscles, providing both stability and mobility. The lumbar region is particularly significant because it bears the majority of the body's static and dynamic weight.
Right. It takes a lot of load.
It does. This constant load, combined with the extensive range of motion needed for daily movements, bending, lifting, twisting, makes it uniquely susceptible to the cumulative wear and tear that characterizes the aging process.
That makes perfect clinical sense. Given its role in weight-bearing and movement, it's clear why degenerative changes there would have such a profound and often symptomatic impact. What does the epidemiology tell us about just how common, and maybe more importantly, how significant this condition is in our patient demographic?
Well, the epidemiological data truly underscores the immense clinical importance of LSS. It is, in fact, the most common reason for lumbar spine surgery in patients aged 65 and over.
That's quite a statistic.
It's a staggering statistic, really, considering the breadth of lumbar pathologies. When we look at the broader adult population, LSS is estimated to affect a significant proportion, maybe 20 to 25% of individuals. Though it's important to stress, not all of these will be symptomatic.
Right. Imaging findings don't always equal symptoms.
Precisely. The average age at which patients typically present with symptomatic LSS is around 65 years. Interestingly, and this is a subtle nuance, it's observed slightly more commonly in males, with a ratio of about 1.5 males for every female affected.
Any reason why?
The reasons aren't entirely clear, but it could relate to historical occupational stressors, or perhaps differing activity levels over a lifetime. We don't know for sure. Crucially, the most frequently affected anatomical level is L4, L5.
Ah, yes.
That accounts for a remarkable 91% of symptomatic cases. This prevalence at L4, L5 is largely due to its position as the apex of the lumbar lordosis, the inward curve. It makes it a transitional segment that experiences immense biomechanical stress during flexion, extension, rotation.
It bears the brunt.
It often does, bearing the brunt of accumulated microtrauma. And to put the degenerative aspect into further perspective, degenerative changes somewhere in the spine are detectable on imaging in up to 95% of people by the time they reach 50 years of age.
95%.
Yes, so this particular insight is vital for clinicians. The mere presence of degenerative changes on an MRI or X-ray does not automatically equate to a symptomatic diagnosis of LSS. It's a common finding, but only a subset will develop the specific nerve compression and inflammation that leads to claudication.
Those are compelling figures, really highlights how pervasive this is and that crucial distinction between radiological findings and actual clinical symptoms. You mentioned earlier that while it's predominantly degenerative, it can affect younger patients due to developmental causes. Could you elaborate on those demographic nuances, perhaps, and how might early detection differ?
Absolutely. While the vast majority of LSS cases, as we've discussed, are degenerative and age-related, we do encounter a smaller but clinically distinct subset of patients with what we call congenital spinal stenosis.
Born with it, essentially.
Right. Yes, these individuals are born with a spinal canal that is inherently narrower from birth. Because this baseline canal size is already compromised, any subsequent, even relatively minor degenerative changes or arthritic processes can affect them much sooner than someone with a normal-sized canal.
So symptoms appear earlier.
Exactly. This leads to the onset of symptoms typically between the ages of 30 and 50, a full 2 to 3 decades earlier than the average degenerative LSS patient. This congenital form is also observed slightly more commonly in men, mirroring the pattern we see in the degenerative form.
Interesting.
Developmental causes can include conditions such as achondroplasia, a form of dwarfism affecting bone growth, leading to a smaller spinal canal. Or, more subtly, it can simply be an anatomical variation where an individual has naturally short pedicles in their vertebrae.
Just bad luck anatomically.
In a way, yes. It contributes to a constitutionally smaller canal size. For these younger patients, early detection often involves a higher index of suspicion when their symptoms present atypically early. Understanding this distinction is paramount because while the symptoms might be similar, the underlying anatomy and the trajectory of the disease differ. It might sometimes require a different long-term management strategy, although the symptomatic treatments often remain largely the same.
Understanding the what is crucial, but what's truly fascinating for us as clinicians is delving into the why. How does this narrowing actually occur at a physiological and biomechanical level? What are the precise mechanisms at play?
Indeed, delving into the pathophysiology is key to truly understanding LSS. It informs both our diagnostic interpretation and our treatment approaches. The primary cause, as we've established, is really a cascade of degenerative changes within the lumbar spine that accumulate over decades. Let's start with age-related disc degeneration. The intervertebral discs, those resilient shock absorbers, are designed to be spongy and highly hydrated, mainly due to their high proteoglycan and water content.
Like little water cushions.
Kind of. Over time, however, a natural part of aging involves a progressive loss of this water and proteoglycan content. The discs become less pliable, more rigid, less effective at maintaining their height.
They dry out and shrink.
Essentially, yes. This desiccation leads to a loss of disc height, much like a tire slowly deflating. As the disc loses height, the hardened annulus fibrosus, the tough outer ring, can bulge inwards, directly encroaching upon the precious space within the spinal canal.
So it's not just a passive thinning, but an active structural change that invades the neural space.
Precisely. It's a bit like a deflating cushion causing the structures around it to sag and buckle inwards.
Yeah.
And as that disc height diminishes, a crucial biomechanical shift occurs.
What's that?
The normal stress that was evenly absorbed by the disc is now transferred disproportionately to the posterior elements of the spine, particularly the facet joints.
The joints at the back.
Yes, the small synovial joints connecting one vertebra to the next, guiding movement. Under this increased abnormal stress, the facet joints also begin to degenerate, initiating a form of osteoarthritis. This pathological process leads to their hypertrophy, meaning they enlarge significantly, and they can also form osteophytes, or bone spurs.
Ah, those bone spurs again.
Yes. And these bony growths, much like the bulging discs, directly encroach upon the spinal canal space, but this time from the posterior and posterolateral aspects.
So pressure from both front and back.
And sides. Furthermore, the ligaments surrounding these posterior joints, specifically the ligamenta flava, also contributes significantly. These yellow ligaments, helping stabilize the spine and lining the back of the canal, can thicken and buckle inwards as they lose elasticity due to repetitive stress and age.
A triple whammy almost.
You could say that. When you combine the bulging discs from the front, the enlarged facet joints with their osteophytes from the back and sides, and the thickened, buckled ligamenta flava, the overall space available for the spinal cord and nerve roots becomes progressively reduced.
Right.
But what's critically important to remember is that these anatomical changes, the mere presence of narrowing on imaging, may or may not produce symptoms directly. Symptoms typically arise when there's an active inflammatory response around the nerves, direct mechanical compression, or often a complex mix of both.
It's the nerve's reaction.
Exactly. It's the nerve's response to the environment, not just the environment itself, that dictates the symptoms.
That paints an incredibly clear picture of the anatomical progression, emphasizing that crucial distinction between structure and symptoms. Beyond these primary degenerative changes, are there other classifications for the etiology of LSS we should be mindful of?
Yes, for a comprehensive understanding, we classify LSS based on its etiology into two main categories: acquired and congenital. Acquired LSS is by far the most common form, largely driven by the degenerative or spondylotic changes we've just detailed. This accounts for the vast majority of cases in older adults. However, acquired causes also include a range of other factors.
Such as?
Well, post-surgical complications like fibrosis or scar tissue after previous lumbar spine procedures. Then there are post-traumatic conditions, say vertebral fractures healing in a way that encroaches on the canal, or malunion. Also inflammatory conditions like ankylosing spondylitis, which can lead to ossification of ligaments and joints, narrowing the canal.
Right, stiffening things up.
Indeed. And even systemic diseases. Paget's disease causing abnormal bone remodeling, acromegaly leading to excessive growth, or fluorosis causing abnormal calcium deposition. These systemic factors can all contribute to or exacerbate narrowing.
A wide range.
It is. Then congenital LSS, as we touched on, refers to a narrower canal present from birth. This can be idiopathic cause unknown or developmental, like an achondroplasia with short pedicles. This distinction is crucial for understanding the patient's history, age of onset, and potentially their long-term prognosis. Congenital predisposition means even minor degenerative changes can cause severe symptoms much earlier.
So we've discussed the overall narrowing, but the spine is complex, isn't it? Different compartments. How do we anatomically classify this narrowing? And why is this distinction so crucial clinically, especially when interpreting imaging?
This anatomical classification is absolutely foundational for precise diagnosis, for correlating imaging with the patient's specific symptoms, and crucially for guiding targeted surgical planning. There are 4 key types.
Okay, what are they?
First, central canal stenosis. This is narrowing of the main central spinal canal itself, typically caused by a combination of ligamentum flavum, hypertrophy and enfolding from the back, and bulging or herniated discs protruding from the front.
Squeezing the main passage.
Exactly. Clinically, we often consider it significant if the cross-sectional area drops below 100 square millimeters or the AP diameter is less than 10 millimeters on axial scans. This type predominantly affects the traversing nerve roots.
The ones still traveling down.
Precisely. The nerve roots still moving downwards within the canal before they exit at a lower level. For example, at L4, L5, central stenosis typically compresses the L5 nerve roots heading towards their exit below L5.
Got it. What's next?
Secondly, lateral recess stenosis. This is narrowing of the subarticular recess, a specific, often triangular tunnel-like space the traversing nerve root must pass through before entering its foramen.
A side tunnel, almost.
You could think of it that way.
Yeah.
The primary culprits here are typically facet joint arthropathy,
Yeah.
with its associated osteophyte overgrowth, particularly from the superior articular facet below, and often ligamentum flavum infolding too. This also results in compression of the traversing nerve root again, like the L5 root at L4, L5.
Okay, so central and lateral recess affect the traversing root. What about the exiting root?
That brings us to the third type, foraminal stenosis. This involves direct narrowing of the intervertebral foramen itself, the bony exit point, often hourglass-shaped, where the nerve root finally leaves the spinal canal.
Right at the exit door.
Exactly. This is largely caused by substantial loss of disc height, effectively collapsing the space. Combined with foraminal disc protrusions, osteophytes, or angulation from scoliosis, it impinges on the foramen. Crucially, this type specifically affects the exiting nerve root. So at L4, L5, foraminal stenosis typically compresses the L4 root as it exits right at that level.
A key difference. And the fourth.
Finally, extraforaminal stenosis. This occurs lateral to the pedicle edge, so outside the main foramen, beyond the vertebral canal. It's often caused by far lateral disc herniations, less common, but can be very symptomatic or degenerative changes in the extreme lateral facet or surrounding tissues. Like foraminal stenosis, it affects the exiting nerve root, for example, the L4 root at L4, L5.
So understanding these is vital for surgery.
Absolutely essential. It profoundly guides imaging interpretation, helps correlate symptoms, and is critical for targeted, effective surgical planning. We need to decompress the exact structures causing the pain.
That level of detail is truly invaluable clinically. So what does this all mean for the patient, like our Mrs. Davies? How do these distinct anatomical compressions actually manifest clinically? Is it just mechanical compression, or is there more to it?
It's both, and it's a fascinating and crucial interplay of mechanical and physiological factors. The most obvious, as you suggest, is the mechanical effect. With any of these types of narrowing, the physical space for the neural elements is simply reduced.
Less room for the nerves.
Yes, and this reduction is often dynamic. It frequently increases with certain postures. A classic example is extension standing upright, arching the back, walking. This posture can significantly exacerbate the narrowing, physically squeezing the nerves further. What's particularly relevant neuroanatomically is that the nerve root, unlike peripheral nerves, lacks a protective sheath called the perineurium. This structural vulnerability makes it inherently more susceptible to direct mechanical compression and irritation.
So even minor compression can cause big problems.
It can explain why even what might seem like relatively minor compression can have disproportionately severe symptomatic consequences. But beyond the purely mechanical, there's a critical ischemic effect.
Lack of blood supply.
Essentially, yes. Nerves, like any metabolically active tissue, have specific nutritional demands, which increase dramatically with activity. When the canal or tunnel is constricted, this limits the blood supply to the nerve roots, impeding oxygen and nutrient delivery. During activity, when demands are heightened, this constriction prevents adequate blood flow increase. This creates a state of relative ischemia within the nerve roots, a major contributor to the pain, numbness, and weakness, particularly during walking or standing.
So it's not just the squeeze, it's the nerve starving for oxygen.
In a way, yes. Effectively suffocating, not getting enough oxygen and nutrients when it needs them most to function properly.
That's a really important distinction. The mechanical versus ischemic impact helps explain the activity-related symptoms. You also mentioned a couple of associated conditions earlier. Could you elaborate on degenerative spondylolisthesis and degenerative scoliosis and their link to LSS?
Of course,
Yeah.
these two conditions are frequently seen with LSS and can significantly complicate presentation and management. First, degenerative spondylolisthesis.
The slippage?
Exactly, a forward slippage of one vertebra over the one below it. Unlike traumatic spondylolisthesis from a fracture, this form is primarily caused by chronic osteoarthritis and degeneration of the facet joints, key contributors to LSS anyway.
Right.
The most common presentation is L4, slipping forward over L5. This slippage directly contributes to narrowing the canal and foramina, leading to LSS symptoms that can be more severe or complex due to the added instability.
And does that affect treatment?
It's a crucial finding because it often dictates the need for fusion surgery along with decompression to stabilize that segment. Then there's degenerative scoliosis.
A curvature developing later in life.
Precisely. An abnormal, often progressive lateral curvature of the spine, usually in the lower back, resulting from asymmetrical degenerative changes in discs and facets rather than a congenital issue. It's quite common in individuals over 65, particularly with pre-existing degeneration.
And the pain.
The pain typically begins gradually and is directly linked with activity, much like LSS. While the overall curve might look minor, it can lead to significant angulation, rotation, and asymmetrical disc height loss in a way that profoundly exacerbates the narrowing, contributing significantly to both foraminal and central canal stenosis.
So they're not just co-occurring, they're linked pathologies.
Often intricately linked, yes. They can worsen the overall symptomatic picture of LSS and sometimes necessitate a more complex surgical approach.
Professor, when a patient like Mrs. Davies walks into our clinic, what are the red flags and classic presentations that immediately point us towards lumbar spinal stenosis? What's the quintessential LSS patient telling us?
The classic presentation often revolves around a constellation of symptoms in the lower extremities, frequently bilateral, but often asymmetric, one leg worse than the other. Patients commonly report pain, a sensation of weakness, or numbness and tingling in their legs, calves, or buttocks. A hallmark symptom is what we call neurogenic claudication, a truly debilitating symptom. Patients describe it as cramping, aching, or a feeling of fatigue in their calves or legs that occurs predictably with walking, often after a specific distance.
Will I have to stop?
Yes, this discomfort demands frequent short rests, typically just leaning forward or sitting down to alleviate the symptoms before they can walk any further. This pain often radiates into one or both thighs and legs, sometimes described as burning, very similar to what patients might call sciatica.
Sure.
But what's truly distinctive, a critical diagnostic clue, is the profound relationship with posture. The pain typically improves significantly with bending forward, sitting, or lying down.
Flexion helps.
Yes, these flex positions, like leaning on a shopping cart or squatting, increase the available space for the nerves, effectively decompressing them. Conversely, the pain worsens predictably, with extension standing upright, walking, any activity, putting the back into extension.
Like Mrs. Davies leaning on her trolley.
Exactly. You'll often hear patients remark on that, or that they can ride a stationary bicycle more easily and for longer than they can walk the bicycle sign. Less common, but indicative of advanced compression, can be a foot drop difficulty lifting the front of the foot, feeling like the foot slaps the ground. They might also describe general heaviness, fatigue, or even restlessness in their legs.
Those are certainly classic descriptors, helping narrow possibilities. Are there any severe or emergency symptoms we need to be particularly vigilant about, where LSS might demand immediate attention?
Absolutely. While rare, LSS can, in severe cases, progress to acute neurological compromise. We must always be extremely vigilant for any sudden significant loss of motor function in the legs.
Weakness, paralysis.
Yes. Or, critically, any acute loss of normal bowel or bladder function, urinary retention, incontinence, or sudden onset of saddle anesthesia, numbness in the perineal area. These are the absolute red flags for cauda equina syndrome.
Which is an emergency.
A true medical emergency requiring prompt surgical intervention, often within hours, to prevent permanent neurological damage. It's also worth noting, as a slightly more subtle but relevant flag, that recurrent urinary tract infections can be present in up to 10% of LSS patients.
Why is that?
It's often an indirect sign of autonomic sphincter dysfunction related to chronic subtle nerve compression. While not an emergency itself, it's a clue warranting further investigation.
That's a crucial point. It truly underscores the spectrum, from chronic discomfort to acute emergency. You've described the classic presentation, but you also mentioned symptom variability. How much can these symptoms range, and what's the actual impact on a patient's daily life?
The variability is indeed considerable. This is where understanding the individual patient's experience is paramount. Symptoms can range from quite mild, intermittent discomfort that barely registers, easily managed with activity modification.
Right, through to debilitating pain.
Exactly. Profoundly debilitating pain, severely limiting mobility and functional independence. For many, the neurogenic claudication makes walking even short distances an insurmountable challenge. This isn't just physical, it leads to significant frustration, social isolation, often a profound impact on mental well-being. Imagine Mrs. Davies, loving her garden, now unable to stand and tend her plants, or finding shopping an exhausting ordeal. Tasks requiring sustained standing, walking, even leg strength become progressively difficult, eroding quality of life. Patients might try coping initially, but for many, the chronic, disabling nature leads them to seek more definitive interventions. It truly transforms their daily existence.
This variability and the profound impact raises an important question. How do we effectively differentiate LSS from other conditions with similar presentations? Given leg pain can stem from so many sources. The differential diagnosis must be robust.
This is, without doubt, one of the most critical aspects. The absolute key is to differentiate neurogenic claudication, LSS, from vascular claudication, from peripheral artery disease, PAD. Both cause leg pain with exertion, but their mechanisms and alleviating factors are distinctly different.
Okay, how do we tell them apart?
Let me outline the key distinctions. For neurogenic claudication, LSS, postural changes do profoundly affect symptoms. Yes. Walking upright causes symptoms. Standing stationary upright causes symptoms, maintains extension. Sitting typically relieves symptoms rapidly, flexion. Stair climbing often easier going up, leaning forward. Stationary bicycle often relieves symptoms or allows longer activity, flexed back. And crucially, pulses in the feet are typically normal.
Because it's the nerves, not the arteries.
Precisely. Flexion dynamically increases space for the neural elements, decompressing nerves and improving their blood supply. Now, conversely, for vascular claudication, PAD, postural changes typically do not affect symptoms. It's purely muscle oxygen demand. Walking upright causes symptoms, muscle demand. Standing stationary usually relieves symptoms, demand drops. Sitting relieves symptoms, activity ceases. Stair climbing often easier going down, less calf effort. Stationary bicycle typically causes symptoms, active muscle demand. And pulses are typically abnormal, diminished, or absent. We look for other PAD signs too.
That's a very clear comparison. What else is on the differential list?
Beyond claudication, we must diligently consider hip-spine syndrome, a common challenge where coexisting hip osteoarthritis and spine pathology like LSS both contribute. The challenge is finding the primary pain generator.
How do you do that?
Sometimes it requires diagnostic injections, say, a targeted hip injection with anesthetic. If hip pain goes but spinal symptoms remain, it helps isolate the source. Other differentials include diabetic neuropathy causing similar numbness, burning, weakness. Always check diabetic control. And in rarer cases, retroperitoneal pathology, a mass or aneurysm, referring pain. A comprehensive approach is paramount.
That's an incredibly clear breakdown, highlighting the subtleties. So once we have a strong suspicion, say with Mrs. Davies presenting with classic neurogenic claudication, how do we confirm the diagnosis? Walk us through the process.
The diagnostic process is comprehensive and systematic, starting well before imaging. First, a detailed medical history. Thorough inquiry into onset, duration, nature of symptoms, paying close attention to aggravating and alleviating factors, previous spine issues, surgeries, other medical conditions, diabetes, inflammatory conditions. This narrative is arguably the most crucial step.
Then the physical exam.
Next, the physical examination. We objectively assess lumbar range of motion, noting limitations, palpate for tenderness, systematically evaluate muscle strength, reflexes, looking for asymmetry, diminution, sensory function, light touch, pinprick, vibration to lower extremities. Observing gait and posture, how they walk, stand, change positions, is vital. It can provoke symptoms in real time.
Any specific tests?
The chem sign unilateral radicular pain worsened by extension and ipsilateral rotation can be indicative of foraminal stenosis. Interestingly, the straight leg raise test, often positive in disc herniations, is typically negative or mildly positive in LSS, as it stretches lower roots compressed in extension, not flexion. Valsalva test is also usually negative.
And a key point about the exam.
Yes, a crucial clinical pearl. A neurological exam done with the patient seated might appear entirely normal. LSS symptoms may only be reproducible with specific provocative movements or sustained postures like walking or standing.
And what about imaging? What's our go-to for confirming LSS, and what specific nuances should experienced clinicians look for beyond just narrowing?
Imaging is critical for confirmation, localizing the level, and mapping extent. X-rays are often the initial step. They give a foundational overview of bone structure, alignment, joint outlines. We see age-related changes, disc height loss, osteophytes, degenerative scoliosis, spondylolisthesis. Critically, we often order flexion and extension X-rays to reveal dynamic instability.
Which might indicate a need for fusion later.
Potentially, yes. However, a caveat, X-ray findings don't always correlate with symptoms. Many asymptomatic people show significant degenerative changes.
So what's the main imaging tool?
The magnetic resonance imaging, MRI scan, is, without doubt, the modality of choice. It provides incredibly detailed images of soft tissues, spinal cord, nerve roots, discs, as well as bone. An MRI clearly shows the extent of central canal and lateral recess narrowing, pinpoints nerve compression, reveals facet and ligamentum hypertrophy.
Both views needed, axial and sagittal.
Essential to look at both to grasp the full 3D picture. But again, the key takeaway, worth repeating. MRI findings of stenosis can also be present in asymptomatic patients. Always correlate imaging with the full clinical picture, symptoms, history, exam. It's a piece of the puzzle, not the whole picture.
What about CT scans?
A CT scan offers excellent detail of bony anatomy, canal shape, size, osteophytes, calcified discs. Useful if MRI is contraindicated, pacemakers, claustrophobia, or when bony detail is the primary concern. Can be combined with a myelogram.
And the myelogram itself?
A myelogram, with or without CT, involves injecting contrast dye into the spinal fluid space. It outlines nerves and cord, vividly showing pressure points at cutoff or wasting of the dye column. Plain film myelography provides dynamic information with flexion-extension views, assessing dynamic compression. But it's more invasive than MRI, carrying risks like headache or infection. Reserved for when MRI is inconclusive or contraindicated, or dynamic assessment is vital.
Any other tests?
Lastly, in certain cases, particularly differentiating from peripheral nerve issues or neuropathies, we might use electromyography, EMG, in nerve conduction studies. These electrodiagnostic tests assess muscle electrical activity and nerve signal speed. Useful for confirming radiculopathy, its chronicity, and differentiating from diabetic neuropathy or peripheral entrapments. This comprehensive, layered approach ensures accuracy and guides treatment.
For many patients, especially those with mild to moderate symptoms or those who might not be surgical candidates, surgery isn't the immediate answer. What are the key non-surgical strategies we employ first, and what's the philosophy guiding them?
That's a crucial point. Non-surgical management is indeed the initial and often highly effective first line. The overarching philosophy is fundamentally to restore function, alleviate pain, and improve quality of life. It's important to clarify. These measures don't improve the anatomical narrowing itself.
They manage the symptoms.
Exactly. They manage symptoms, improve coping mechanisms, and functional capacity. Often the most beneficial approach involves a combination of time, judicious medication use, postural management, targeted stretching, and a structured exercise regimen, all aimed at managing flare-ups and improving daily endurance.
Let's delve into medications first. What are the main options and any clinical pearls regarding their use in LSS?
We typically begin with anti-inflammatory medications, primarily NSAIDs, ibuprofen, naproxen, celecoxib, prescribed to reduce inflammation around compressed nerves, a significant pain contributor. Crucial to advise careful, judicious use, especially long-term due to side effects, gastritis, ulcers, renal impairment, cardiovascular risk.
Short courses, maybe?
For acute flare-ups, a short course, 5 to 10 days, can provide significant relief. For general pain, various analgesics, from paracetamol to stronger prescription meds, always mindful of long-term opioid risks. Other options might include muscle relaxants for associated spasms, and for neuropathic pain, neurotrophic drugs like gabapentin or pregabalin can modulate nerve pain signals.
What about injections?
A significant non-surgical option, often used when oral meds aren't enough, is epidural steroid injections. Injecting corticosteroids, powerful anti-inflammatories directly around nerves or into the epidural space.
Targeting the inflammation directly.
Precisely. Reducing inflammation at the site of compression, decreasing swelling and pain. While they can effectively reduce radicular pain and numbness, a key point, they typically do not improve motor weakness. We generally limit these to no more than 3 per year due to systemic steroid risks and local complications.
How long do they last?
Evidence, including RCTs, suggests effectiveness for pain relief can last up to 6 months. This offers a crucial window for patients to engage in physiotherapy and improve function.
Beyond drugs, physio and exercise are often highlighted as foundational. What's the specific approach for LSS patients? How does it differ from general back pain regimes?
Physiotherapy and structured exercise rehab are truly cornerstones here. The primary goal isn't to cure the stenosis, but to stabilize and protect the spine, build endurance, help patients resume as normal a lifestyle as possible. It involves a highly tailored program focusing on several areas.
Like core strength?
Yes, strengthening core muscles, deep lumbar stabilizers, and abdominals, improving overall spinal and lower extremity flexibility, and increasing cardiovascular endurance. The emphasis is crucially on exercises enhancing function and alleviating symptoms without excessive spinal pressure.
So favoring flexion.
Exactly. Favoring flexion-based exercises and avoiding activities inducing spinal extension. Good strengthening examples include squats, bridges, planks, building core stability without excessive spinal loading. Patients are taught specific activities and stretches promoting flexion. Double knee to chest, child's pose, temporarily increasing neural space.
And cardio.
Low-impact aerobic exercises are highly recommended. Cycling, especially stationary where the back is flexed, or swimming, which unloads the spine, are excellent choices. Typically, we encourage a structured course of 4 to 6 weeks of dedicated physio, with ongoing home exercises. Research confirmed exercise programs and epidural steroids are effective up to 6 months, highlighting their role in a multimodal approach.
Are there other non-surgical modalities, perhaps less conventional ones, commonly used? What's your take on their efficacy?
Yes, several others are explored, often as adjuncts. Lumbar traction is sometimes used, typically flexed, theoretically aiming to decompress. However, results are generally limited, and there isn't strong scientific evidence from rigorous trials proving long-term effectiveness specifically for LSS.
What about acupuncture?
Acupuncture is another modality many patients find helpful, particularly for pain management in less severe cases. Generally safe with a qualified practitioner, but similar to traction, long-term success addressing root causes isn't scientifically proven through large-scale trials. That said, for symptom relief, it can offer benefits for some.
Chiropractic.
Chiropractic manipulation can also help pain and mobility in some, generally safe for appropriate cases. However, caution is strongly advised for patients with underlying osteoporosis or significant disc herniations, as certain techniques could theoretically worsen symptoms or cause injury. Clear communication between clinician and chiropractor is crucial. In some regions, traditional Chinese medicine, TCM, moxibustion, cupping, herbal remedies alongside acupuncture is used. Efficacy varies, but some reports suggest positive contributions to symptom management.
It's clear a multi-pronged approach is often key. What about lifestyle changes? How important are they in conservative management?
Lifestyle modifications are absolutely vital. The bedrock of successful long-term conservative management, even potential prevention. We strongly recommend weight management to reduce mechanical load on the lumbar spine. Every kilogram lost significantly reduces the burden.
And smoke.
Nicotine cessation is critical. Smoking negatively impacts disc health by impairing blood flow and nutrient delivery, hindering healing. Patients should also engage in bone-strengthening endeavors, adequate calcium, vitamin D, weight-bearing exercise to maintain spinal integrity, mitigate osteoporosis. Maintaining good hydration, a balanced anti-inflammatory diet supports overall spinal health.
What about modifying activities?
Activity modification is crucial. Teaching practical ergonomic tools for lifting bending, importance of frequent breaks from prolonged sitting standing to alter spinal loading, breaking down strenuous tasks into smaller steps. These consistent conservative measures form the foundation, maximizing function and pain relief, often allowing patients to avoid or significantly delay surgery.
Professor, for those patients where non-surgical approaches don't provide sufficient relief, or when there are more severe neurological concerns compromising function, surgery becomes a vital consideration. What are the precise indications telling us a patient might benefit? This is critical for our listeners.
You've hit upon a truly critical juncture. Surgical intervention is a significant step, and the decision is based on clear, systematic evaluation of specific indications. There's one absolute indication: Cauda-Equina syndrome. As discussed, a medical emergency demanding immediate surgical decompression to prevent permanent neurological damage. Non-negotiable.
Right. What about relative indications?
Beyond that, we have relative indications, coming into play when non-operative management, despite a concerted effort over typically 3 through 6 months, has failed. These include persistent disabling pain in legs, buttocks, or calves, significantly limiting normal activity or quality of life, making standing walking difficult, like Mrs. Davies' situation.
And neurological decline.
Yes, progressive neurological deficits, a key concern. Objectively worsening leg weakness, new or worsening foot drop, increasing numbness, indicating ongoing nerve damage. Also, intolerable neurogenic claudication, where walking distance severely limits independence. And loss of normal bowel bladder function, even if not full Cauda-Equina syndrome. Progressive issues warrant surgical consideration. Finally, the patient must be in reasonably good health for surgery, comorbidities controlled, risks acceptable.
And a key point about back pain alone.
Profoundly important to emphasize. Isolated low back pain, without neurological deficit or disabling claudication, is generally not an indication for LSS surgery. The focus is primarily on neurological symptoms and functional limits.
So once the decision for surgery is made, what are the primary surgical options? I understand it's broadly decompression, maybe with fusion.
That's absolutely correct. The overarching goal is fundamentally decompression, creating more space for compressed neural elements. The most common foundational procedure is decompressive laminectomy, surgically removing the lamina, the bony roof, along with thickened ligamentum flavum, to directly relieve nerve pressure.
Open or minimally invasive?
Can be performed open, larger incision, direct visualization, or increasingly via minimally invasive techniques, MIS. Smaller incisions, specialized retractors, often endoscopic or microscopic visualization. MIS often means less muscle dissection, reduced blood loss, shorter stays, quicker recovery, but requires specific surgical expertise.
Can you describe a typical laminectomy?
Okay, a single-level decompression at L4, L5. The most common site typically involves precise resection of the inferior half of the L4 spinous process, removing the L4 lamina up to the ligamentum flavum insertion. The thickened ligamentum flavum itself is meticulously resected, often followed by medial facetectomy, careful removal of the overgrown inner facet joint part, and lateral recess decompression, ensuring traversing nerves are free. We also explore foramina, ensuring exiting roots have space. The aim is pedicle to pedicle decompression.
And the results?
Generally, significant improvement in leg pain, improved function, high patient satisfaction. Leg pain typically shows more profound improvement than isolated back pain.
Are there other decompression techniques besides classic laminectomy?
While laminectomy is most common, there are variations. A laminotomy creates a smaller, localized opening in the lamina, preserving more bone. A foraminotomy specifically enlarges the bony exit for the nerve root. Can be done alone if stenosis is purely foraminal, or with laminectomy. As mentioned, medial facetectomy removes just the overgrown facet part, causing compression. Choice depends on the precise location and extent of narrowing.
And when does fusion enter the picture? Often a point of debate. What are the specific indications for adding fusion to decompression? And what are the main types?
Spinal fusion is indeed more extensive, creating a solid union between vertebrae, stabilizing that segment. Not always necessary, but indicated in specific circumstances to prevent instability or manage existing instability. The decision is based on careful pre-op assessment and sometimes intra-op findings.
What are those key indications?
Key indications include 1. Degenerative spondylolisthesis. Significant slippage, especially if symptomatic or radiologically unstable, 3 mm translation or 11-degree angulation on dynamic x-rays. Fusion often recommended with decompression. 2. Radiological instability, objectively seen on dynamic imaging showing excessive movement. 3. Intraoperative destabilization, a critical decision. If radical decompression removes 50% of facets bilaterally or entire facet pars, the spine can become unstable. Fusion restores stability. 4. Degenerative scoliosis. Significant curvature contributing to instability or complex compression, fusion may be needed. 5. Significant low back pain disc degeneration. If significant disc degeneration contributes to chronic axial back pain and instability alongside stenosis, fusion may be considered.
And the types of fusion?
Several common approaches. Anterior lumbar interbody fusion, ALIFF. Through lower abdomen, remove disc, place cage with bone graft. Posterior lumbar interbody fusion, PLIF. Through back, remove posterior bone, retract nerves, place bilateral cages. Transforaminal lumbar interbody fusion, TLIF, posterior approach, often unilateral through foramen, less nerve retraction. Posterolateral fusion, bone graft on backside of the spine over transverse processes lamina. And instrumented fusion refers to using hardware screws, rods for immediate stability, while biological fusion heals, improving fusion rates.
Before we move to outcomes, a quick but important question. What's the impact of preoperative opioid use, and what does post-op rehab look like?
A very pertinent point. Preoperative opioid use is indeed associated with several adverse outcomes. Studies consistently show patients on chronic opioids often have prolonged hospital stays, increased post-op pain needing higher doses, greater complication risk, possibly due to opioid-induced hyperalgesia tolerance issues. We counsel patients about this, aiming for opioid tapering pre-op if possible.
And rehabilitation.
Post-surgery rehab varies. Simple decompression. Patients might go home same or next day. Fusion extends stay to 2-3 days, maybe longer with comorbidities. Key principle: early ambulation. Walk as soon as possible post-op. Brace corsets, sometimes used for comfort. Physical therapy is crucial: strength, endurance, flexibility, core stability. Highly individualized programs.
Return to work. Activities.
Desk job return. Few days to few weeks. Full normal activities. 2-3 months post-decompression, often longer, 6-12 months post-fusion as bone heals. Older patients might go to a rehab facility first. Post-op opioids. Short course, typical after laminectomy, maybe longer after fusion. Pre-op opioid users may need careful tapering.
It's essential to consider benefits and challenges of surgery. What do Outman's data tell us about effectiveness, particularly quality of life improvements, and what are the risks we need to discuss?
The good news is, overall results of laminectomy plus med-fusion for stenosis are generally good to excellent in most patients. Consistently observed. More significant improvement in leg pain than back pain, though back pain often improves too. Most resume a normal or significantly improved lifestyle after recovery.
Any key studies?
Landmark study. The SPORT trial, large RCT comparing operative versus non-operative for stenosis. Followed 289 patients for 4 years. Operative group consistently showed significantly improved pain and function, pivotal in demonstrating surgery's efficacy for appropriately selected patients.
What about decompression versus fusion?
Evidence informs this debate too. A meta-analysis suggested decompression without fusion best for symptoms 8 years. For symptoms 15 years, decompression with instrumented fusion gave best outcomes, while decompression and fusion without instrumentation had worse results. Highlight stabilizing segments with likely long-term instability. Interspinous devices like X-stop also showed promise in select patients in some trials, though long-term role complications still debated.
So, while outcomes are generally positive, what are the potential pitfalls? Specific complications of LSS surgery we need to counsel patients about.
As with any surgery, inherent risks exist. General risks, bleeding, infection, blood clots, anesthesia reaction, usually very low. But certain patient factors elevate risks. Elderly, overweight, diabetics, smokers, multiple medical problems.
And specific LSS surgical complications.
Yes, specific complications warrant thorough counseling. One common one, dural tear in the sac covering nerves, often repairable intra-op, but can lead to CSF leak, bed rest, headaches, even resurgery. Risk of failure of bone fusion, pseudothyrosis if fusion done, or hardware failure, screws rods, potentially needing revision. Nerve injury is rare, but serious transient neuropathy is more common, persistent deficits rare. Genitofemoral obturator nerves can be at risk with certain approaches. We monitor nerve function intra-op. Always the risk of failure to relieve symptoms or symptom return later. Adjacent segment disease, restenosis. Infection is a concern. Wound infection 1–3%. Systemic infections like pneumonia 5%. UTI surprisingly common 34%, often catheter-related. Major infections need debridement. Persistent neurological deficits 4%. Transient deficits more common 36%, usually resolving. Other potential major complications: renal failure 5%. Anemia needing transfusion 27%. Post-op confusion 27%. Complication rates generally increase with age. Blood loss, number of levels fused.
And what about reoperation rates? What commonly causes patients to need subsequent surgeries? And how do we manage that long term?
Reoperation is a significant consideration, discussed openly pre-op. Most common cause of failed surgery need for reintervention is recurrence of disease above or below the initial level, often called adjacent segment disease or stenosis.
Why does that happen?
Fusing a segment alters spine biomechanics, placing increased stress motion at adjacent unfused segments. Over time, this accelerated wear leads to new degeneration and stenosis there. Happens in a significant proportion, cumulative rates up to 25–30% needing reoperation at adjacent level within 10 years post-fusion.
Any other reasons for reoperation?
Another common reason is restenosis narrowing recurs at the same level initially decompressed, due to soft tissue regrowth, ligamentum flavum, scar tissue, or progression of underlying degeneration. Highlights LSS as chronic. Even successful initial surgery requires long-term management vigilance as degeneration continues. Understanding reoperation risks is crucial for realistic expectations and follow-up.
Professor, this truly highlights the lifelong journey many patients face, the chronic nature. So beyond acute treatment and rehab, are there specific preventive measures we can recommend to mitigate progression and manage symptoms long-term?
Given the chronic progressive nature and no current definitive cure reversing degeneration, emphasis must shift profoundly to proactive long-term management, aiming to halt symptom progression, prevent flare-ups, maintain improved quality of life and function. Remember, comorbid conditions are often strongest predictor of outcomes. Managing diabetes, heart disease, obesity is paramount. Rehabilitation remains key, especially for deconditioned patients.
What practical preventive strategies can we empower patients with?
Several key areas. Firstly, activity modification and ergonomics. Adapting daily routines to minimize chronic spinal stress, using ergonomic tools for lifting, bending, emphasizing frequent breaks from prolonged sitting, standing, breaking down strenuous tasks into smaller steps, working smarter, not harder, to protect the spine.
And exercise.
Secondly, targeted exercise and physical therapy. Crucial not just for rehab, but prevention and long-term management. Personalized programs enhancing core strength, flexibility, endurance without excessive spinal pressure. Consistent engagement in exercises like squats, bridges, planks, incorporating flexion stretches like double-kneed chest, low-impact aerobics, cycling, back flex, swimming, unload spine. Consistency is key.
What else? Broader lifestyle factors.
Thirdly, broader lifestyle recommendations. Maintaining optimal hydration, balanced anti-inflammatory diet, empowering patients with self-management strategies for flare-ups. Smoking cessation is non-negotiable.
Mobility aids, home changes.
And finally, mobility aids and home modifications. For some, Walking sticks, rollators, braces provide support, reduce pain, allow longer activity. Simple home modifications. Handrails, non-slip mats, keeping items within reach, minimize bending, reaching, improving safety, and reducing strain. These proactive, multifaceted strategies, adopted consistently, help mitigate risks, manage symptoms, promote better long-term spinal health.
Prof. Mo Imam, this has been an incredibly insightful and profoundly detailed deep dive into lumbar spinal stenosis. We've truly unpacked everything from its definition and pathophysiology through clinical presentation, diagnostics, the full spectrum of management, right through to outcomes, complications, and prevention. It's really highlighted the multifaceted nature, the importance of precise diagnosis, and the critical role of both conservative and surgical options, always with that essential long-term perspective.
Indeed. If we connect this to the bigger picture, it's clear that optimizing outcomes isn't just about technical expertise. It's profoundly about patient education and truly understanding their individual journey. Are we truly preparing our patients, like Mrs. Davies, for the chronic nature of this condition, emphasizing self-management and realistic long-term expectations? Or are we sometimes inadvertently setting them up for disappointment by focusing solely on a fix? That's a question we, as clinicians, must continuously ask ourselves.
A profound thought to end on, and one that resonates deeply with the realities of clinical practice. Thank you so much for your invaluable insights. Your expertise has truly illuminated this complex topic. And to our listeners, we hope you found this deep dive valuable. If you did, perhaps take a moment to rate and share the show. It genuinely helps more medical professionals find these crucial conversations. We look forward to joining you again on our next deep dive into another critical medical topic.